So our next patient is a 44-year-old male who presented with jaundice, and the CT scan revealed dilation of common bile and hepatic duct. ERCP was 3 times unsuccessful, and the diagnosis is yet unknown. Therefore, we decided to perform the biliary drainage using EUS-guided choledochoduodenostomy, and the procedure will be performed by Professor Binmoeller and Dr. Zavada.
Okay, so I am just now intubating the patient with the echo endoscope. I'm actually very happy that the ERCP was not successful and that a stent was not placed, because if their stent were in place, then we would have difficulty seeing the head of the pancreas. And our primary suspicion is that there is a... Can you do a little jaw thrust here? I'm not getting my scope in so easily. Yep. Now this is a therapeutic echo endoscope, which is what we need if we want to place axials, but it is a little bit thicker, and so you have to be more careful when you're passing the scope down. And I have a little bit of resistance here, so one moment, I'm going to pull back and try again. Now I'm in. Okay, so I'll just take you, this is an oblique viewing scope, and that means you use it like a duodenoscope. As you're passing, it's important to visualize the GE junction. So you see, I see the wall of the esophagus as I'm going down, and patients may have a large hiatal hernia or a Schatzki's ring. These are all areas where you can perforate. So it is important that you see these landmarks as you're passing down. I'm in the stomach now. I'm just sucking out a little bit of fluid. He is intubated, so obviously the risk of aspiration is minimized. So now we pass down. We can see very nicely the antrum. Here's the pylorus. Okay, sundown, we go into the bulb. I'm going to stop here at the apex of the bulb, and this is where I start my imaging. So let's switch now to the EUS large, and let's magnify up. You already see the bile duct very nicely. It's definitely dilated, and I want to follow the bile duct, so if we can magnify up. Let's see, where is the magnification? Magnify again. And one more time. All right, so now with the apex, with the scope at the apex, we can follow the bile duct down to the ampulla. It's tortuous, and right there you can see the ampulla. So how is it that we see the ampulla even though we're in the bulb? Well, the reason why is because we're sort of looking through. We're going to get a different view of the papilla in just a moment, but we want to get multiple views of the anatomy. That allows us to confirm our findings from multiple views, including later the transgastric view. So here, there's the papilla here. Now I'm coming up, and I'm looking for any mass. Now I'm above, and often you'll see the takeoff of the cystic duct. Now this is the common hepatic duct. Right, you see the bifurcation here at the hilum, the left and right hepatic ducts. I'm going to come back down again. You can see it's tortuous, and it makes another turn here, like a sigmoid, and then it comes down here. But this is the area that I'm looking to see. And look, you can see that there's something right above. There is a small mass here. And if you freeze, let's mag up even more, please. Increase the magnetic, and one more time. Look at this. Look very carefully. You can see above now, and then as I come down, here you're going to see some thickening right in this area. So it's concerning. It's either a pancreatic head or it's biliary mass here. Let's go into the second duodenum now and look, because this is the most important part of the examination. Is why is this patient jaundiced? It already raises primary concern for malignancy, so decrease the magnification. Now I'm in the second portion. You can see on the endoscopy, I'm in the second portion, and I look for the mesenteric vessels. See the mesenteric vessels? There's the SMV, and below it the SMA. SMV, SMA. There's a little lymph node there, although it looks benign probably, but there is definitely a lymph node. You can magnify up once, and we could also sample that. If you look at it, it's a little bit irregular. If you freeze and measure that out, that's a lymph node. So it's next to the superior mesenteric vein. So that potentially should be sampled. All right, so now we have 1 centimeter. Okay, take that off, please, and we'll continue. So you see very nicely the mesenteric vessels, and I keep pulling back the scope very slowly. See, this is the most critical part. Let's mag up more. So I'll magnify when I really want to look at the detail. And so this is the area I want to see very carefully. And I'm just rocking back and forth with my body to see the head of the pancreas. I think we see the PD coming there.
Yeah.
Hard to say right now. What's causing that artifact here? That's the aorta. Okay, let me come back a little bit more. So I really do need to see this area. I'm going to blow up the balloon a little bit more just to prevent myself from falling back too far. Hopefully I'm going to get a good view of the papilla and the distal bile duct. That's what I'm hoping for. Very slowly, just turning carefully back and forth, trying to hold my position here. Look at this. It's looking, look at that, right? There's some thickening there.
Should we freeze and show?
Yeah, and magnify it again, magnify. See, there's something going on here. There's something here. Okay? Definitely, this is, I think, a small cancer.
Right here.
Right? That whole area there, yes. 44-year-old male. And the good news is, unfreeze please. The good news is, I don't think it's involving any neighboring structures. And we should be able to see the bile duct above it in a moment. I'm going to try to tease it out. See, there's the PD, right? There's the PD coming back very slowly. Ah, now we get it. Magnify up. This is where the cancer is starting to block the bile duct, right here. Okay, as I pull back a little bit more, you start to see on the far right side is the bile duct lumen. But this is the cancer here. It's a cholangioCA, I think, because if you look at the cancer, the hypoechoic area, it's longitudinal. It's following the duct, but it goes outside the confines of the duct. Coming back just a little bit further. Here, look, there's the bile. Whoa, I slipped back. So I'm sorry, I slipped back. But I know now that there definitely is what looks very concerning for cancer, and probably cholangioCA. Now, one could have a discussion with this finding, should this patient, with this alone, go to surgery? And should we just sample this today? Or do we want to drain the bile duct? And the only reason to drain the bile duct would be if we wanted to give neoadjuvant treatment first, right? Then there would be a delay, and so we have to drain the bile duct. In our hospital, we would send this patient right to surgery. And one could even argue for not even doing FNA because this has to be removed. In other words, it's not going to change what we do. There's enough suspicion that this is cancer to warrant just going to surgery. Now, if we could drain the bile duct easily here under EUS guidance, right? We have a nice spot here that we could use to gain access. So now what I'd and here we can see an area. I'm trying to find an area. This is in the bulb where you can see, maybe if I can see that mass a little bit better. You see it to the far right a little bit, but it's not good enough for me. So I probably have to do the biopsy from the second duodenum, which is going to be a little bit more difficult. The FNA is not an easy FNA.
Takže acquired 22 is okay. Yeah?
Yes, acquired 22 is fine. So I'm going to go back into the second duodenum, and I think that would be the best position to do the FNA. If you would like, you can go to another case, and I'm going to get everything into position, and we can internally discuss what the management should be.
Okay, it sounds like a plan. So we can be back in a few seconds after everything is ready, and in the meantime, we will here discuss whether it makes sense to not drain this patient and proceed into surgery, or if there are some issues that will force us to drain him today. Yeah?
Okay, so I'm going to do, this is very important, is to get the FNA. We decided we want the tissue. We also decided that we want to drain the duct. So you can see why ERCP failed. It's because this cancer is invading into the duodenal wall. You see the musculars propria there, and the cancer is right below it and invading through the musculars propria. Please magnify up one. So I inserted our FNB needle, and I'm just going to thrust the needle into the lesion. I'm just pulling back a little bit. You can see my back is to the patient. It's the only way I can get into position here. And then I'm just going to thrust like that. Okay, now we're going to start a slow pull back as I go back and forth. And I'm going to try my best to fan out the area to try to get some different parts of the cancer, of suspected cancer. There it is. There's some firmness here, definitely. Okay. And I just go back and forth, and you're doing a slow capillary pull, right? That's just pulling the tissue with capillary suction into the needle. All right. Just turn this way. Ah, you see it better here, even better, right? This is a better. See how I'm having to turn my arm here to get into the right position. You can see my head is completely turned. This is why it's important to have a unit with a swingable boom, right? A boom that you can swing. Okay, are you out? Yeah, keep pulling until you're out, please. And this is Hannah helping me. Wonderful, Hannah. Thank you. Okay. There we go. All right. Pull all the way out. Pull all the way out. That's good. Okay. And now I'm going to pull back.
Philip, can you hear me? Philip?
Yeah. Hello.
Can you show for the people in the room who are not doing EUS the basic structures that we can see, like instrument, duodenal wall, and the lesion itself?
So I tried already. So this is okay.
Yeah,
so
we can see the cursor now. Yeah, thank you.
And this should be the MP of the duodenal wall.
Correct.
Yeah, and this is the submucosa.
Okay, very nice.
So, and this is the tract of the FNA. Okay, like this, and this is probably the best view here.
Yeah,
and here you see the maximum extent of the lesion, which is about 2 centimeters, I guess.
So it looks like periampullary tumor, doesn't it? Because we can see both ducts on the left side.
Right. And we speculate that it originates in the CBD.
I think it's CBD, and I don't think the PD is dilated. So let's look. The intrahepatic ducts, I'm in the stomach now.
Yes.
So what I'll do is quickly take a look at the pancreas to see whether there is any dilation of the pancreatic duct. There is a little dilation. There is. There's the PD here. This is the neck. And now coming up to the body. And now I'm following the PD down. So it's a little generous down towards the tail. And as part of the staging, it's very important to, there's the adrenal gland. This is the kidney, left kidney, adrenal gland above it. And there's the aorta. And we're going to look at the celiac trunk. Just make sure that there's nothing there. Here's the celiac trunk coming off. So I don't see any lymph nodes in this area. Now remember, we saw a lymph node that was adjacent to the superior mesenteric vein. So I'm going to go down and see if I can visualize that.
In the meantime, this is all we've got, which is good, I think.
All right.
Should we put it in the formal or?
Well, so in our unit, we have a pathologist come and look at it. The reason for rows is only because if it's positive, then you have a clear indication, to proceed with, with a metal stent, be it Axios or with a SEMS. So I guess the question is just, since this patient is going to surgery, is there any concern about placing a LAMS transduodenal, so performing a colodocal duodenostomy? And that's really a question that I think every one of you in the audience needs to ask your surgeon, because it's primum non nocere, right? First, do no harm. And if the surgeon is concerned that the LAMS may in any way impact the surgery, the Whipple operation, then that would be a reason maybe not to do it. So I can tell you right now, our surgeons prefer that we not place a LAMS if the patient's going to surgery.
Yeah.
Until we have better evidence to clearly show that we do not in any way negatively impact the outcome of a Whipple. So that's why in our unit, this patient would actually go to surgery. But I understand if you want to drain this, I think the only way that will work, he's already had 3 failed ERCPs. It doesn't make sense to try yet a 4th one. You may even, get pancreatitis from it. So I'm willing to do a colodocal duodenostomy if that's what everyone wants, including maybe the surgeon.
Okay. So I think that is a general opinion that it's needed. Yeah.
Okay.
There is an opinion in the floor that maybe it can interfere with future surgical procedure in Czech environment. Definitely in my university hospital that is doing a lot of pancreatic surgery procedures. We always call the surgeon from the ERCP room to discuss, and I think in this situation they would say, do not touch the ligament. We want to have a free access without those axios.
Yes, it's true. That's the same in our unit at this time, right? The evidence is simply not there that a LAMS will not negatively impact the outcome of a Whipple. Technically, it's doable, and if we do it, you need to be sure that you're at the apex and do not place the LAMS too close to the pylorus because you'd want to do a pyloric-sparing Whipple. So remember the earlier pseudocyst drainage, how I ended up more proximal than I thought?
Yeah.
This cannot happen because that will be a problem for the surgeon if the LAMS is too far proximal. So I have to err on being more towards the apex. So just let me know what you would like me to do. I'm happy to go forward. This would be where I would go. And so what we want to do is to find a place where we have the longest runway. Remember what I explained about the runway? And the runway, if we're going to use, let's say, an 8mm LAMS, then the runway needs to be somewhere around 25, so over 2 centimeters.
Thank you very much. Thank you. Sorry to interrupt you again. So we will definitely go back. So we are just moving to the gastroscopy room, and we'll be back. And we are also calling our surgeon. So please don't do that. Can you hear us? So please don't do anything right now. We are calling our surgeon. We are going to another room, and we will tell you.
Primum non nocere. Absolutely, I agree.
Okay. Thank you.